Good morning, everybody. I'd like to thank the organizers, Noor and Ellen, for the invitation to present some of my work and also some literature review about the herbal remedies that I've been working on. I've been working on herbal remedies since 2006 after two urologists in Hong Kong came to me and asked me, do you have any idea of a biochemical workup on patients taking certain herbal drugs? And I said no. So that's where we started working on patients taking herbal remedies. When we define herbal remedies, I should define certain definition actually. There are herbal medicines that may be also classified as Ayurvedic, and they have specific pharmacokinetic effects. And then there are these naturopathic, which are nutrition based. And then there are these homeopathic herbal drugs that are only symptomatic for treatment of pain. So we have to be clear what we are talking about when we talk about herbal medicines, because they may be classified differently. As you know, I think it was earlier yesterday, that there's tons of literature on the internet, and once a patient gets a stone, the first thing he goes on is in the internet, what's happened to me? And let me see how I can solve this. So they will look at all this literature. Some of the works that have been done, this is not exhaustive. In fact, this runs over 4 pages. So, but I'm just highlighting that much of the work is in vitro in animals. Very few studies, as you see on the top 3 rows, are on humans, and that too is in vitro. That means the urine is taken out for studies. Very few in vivo studies. And if I look at in vivo studies, that is follow-up studies, it's only in a handful, 4 or 5 actual studies that have been done in vivo with herbal medicines. And those, I'll lay to you in a moment. Some of the drugs, herbal medicines that have been widely reported in vitro and in vivo, the one on Hanuria hirsuta, that has been published quite a lot. And this herbal medicine comes from Morocco. Philanthus niruri, Brazilian folk medicine, Campo mixture that is very popular in the Asian region in general, and then there's a big group of herbal medicines coming from India and the subcontinent, and these are the Passion Beta Ayurvedic drugs that are used. So there are papers on these that are printed. But when we look at all the studies and literature review, we see that the clinical trials are very sparse, and the earliest one that I can pick out, a good study that is by Michele in 2006, where he did a follow-up studies on patients with ESWL and found that it does help to increase stone-free rate using Philanthus niruri, the Brazilian folk medicine. A follow-up paper by another different group indicated also using this in vivo that it increased antioxidant activity and prevention of oxidative stress. So there are some work still ongoing. There is also one in vivo study done from Shekhar Kumaran to show that it does decrease in stone parameters and episodes. Stone parameters meaning nucleation rate and as well as crystals in the urine. And then a recent study by Rogers showing that Folium Paraceae, that's a drug that I was also working on, having no effects as a therapeutic agent. So these are the few handful of studies that you'll see available in the literature. Then what's the problem? Problem is most of these herbal drugs have a complex mixture. And I'll give you an example. I'm a tea drinker. If you have English breakfast or Earl Grey tea, from whether it's Lipton or it's from Dilmah or it's from Tetley's, they all have different preparations, aroma, intensity, because they are plant-based, and how they prepare them is different completely. So no 2 plants are equal, especially when they come in preparation. What type of international safety certification do they meet? Study design, compliance. I'll talk about compliance in a moment because we did a clinical trial which we had to abort, and it was basically due to compliance. We had to abort the study. And what has happened is ESWL is now becoming so fashionable, it's become a lifestyle actually. So people walk into the urologist, can you remove this stone? I need to get back to a meeting at 1 o'clock in the afternoon. this is how they're dealing with it over there. So with that, we are unable to get any metabolic workup post that because they're busy, they come in, they leave and go back to work in a meeting after lunch. Now, what's the implications? I think there are many clinicians here, and if you ask your patients honestly, have you tried anything alternate medicine or any alternate therapies? I can assure you 80% of the patients will say, yes, I've tried that. Even if it's simple cranberry juice or something else like that, they will have looked up internet. And this was what we found in our survey also. In a WHO report, in looking at ethnic population using traditional medicine, not only in kidney stones, but in all chronic diseases, it was found that 40 to 85% of the ethnic population will use drugs that they understand or therapies that they understand in the languages. So I think it's important for clinicians to understand this. And some people will hide away this. So this one. So what we have in our demographics, what Hong Kong government was doing at that time was, it realized that every neighborhood there's a herbal therapy, not a shop, but a clinic. So what the government went ahead and did was, when we did our study was, we found that 8.5 to 12% of Hong Kong population had used TCM in renal stone patients. And in a recent study that we did was in 2007, it was almost 40% in renal stone patients and 90% almost in chronic disease. I work in other bladder cancer and as well in liver cancer, and in those studies it's almost has 90% they will use alternative therapies. In the cohort of study that we were doing, 48%, almost 50% had accessed TCM. This is traditional Chinese medicine. So the socio-demographics has changed. So it is gaining popular. So the government did was, it now has basically regularized, made a regulatory authority that all TCM practitioners have to be registered. Any prescription has to be detailed and recorded, so they know what patients are taking. So if a patient goes to any TCM, it is recorded what they have taken and it's put in a database. And I'll tell you about this in a moment when we did our study. So WHO has listed about 20,000 plants, of which about 80 of them are for kidney stones. So what we did was we linked up with a clinical trial center at Chinese U. We used one preparation coming from a single source, and it had a good manufacturing process. That was the drug that we used, SEC-Y, and this is the earlier study I'm talking about, alluding to. So it is known to induce diuresis. Seldom has any reports, there's been no reports of side effect. Now this was one of the challenges that I had because I had to use my research student who knew Chinese to look up all the Chinese literature to see for side effects and all that, and there are tons of papers on this if you go into Chinese literature, but there's no translation available. So we did a randomized double-blinded placebo-controlled study. Basically, this is the outline. We had 48 patients. We split them into a patient group and a placebo group. That's the drug that we use over there. That's on the top the Puropharm. They make a consistent, and it's a very popular TCM drug company. This is the split that we did with the urine. Now, 24-hour urine, I would love it. It's just very difficult, but in my longitudinal study, I did use 24-hour urine. But at this time, we were using only early morning urine. So we had the urinary parameter, crystallization studies, and also to look at the oxalate tolerance test for metastable limit. These findings are very reported, but just to give you a brief thing, we found that the specific gravity decreased significantly. That was a diuretic effect. We saw the calcium just slightly increased, but it's not significant so. But the magnesium was definitely increased in the patient group. So the initial results do confirm, and we did this study, that it has a sort of what I call it an aquatic effect, because it's not diuretic. I don't see sodium, potassium going high or anything, so it's not working on the loop diuretics or anything like that. And the beneficial effect of magnesium is well known. If magnesium is there, magnesium oxalate is much more soluble, so it would help the patients. And there were no statistical differences in the parameters that we look at for the crystallization, except that when we looked at the patients, they had much more smaller numerous crystals, which I think helped them to reduce their relative supersaturation. So what we did follow up was this study extended into a longitudinal. So in 2009 onwards, we started looking at these patients up to now. So 5 years you're looking at. So we had 15 subjects from each group. They were given 1 gram per day every day, and patient details were linked up to the hospital and TCM clinic. So in Hong Kong, we have an ID card, unique number, and we can follow the patient wherever he goes. And as soon as a drug gets dispensed, we know what he's taking. So we started the study in May 2010, asking them to follow up every 6 months. And what happened was we had to terminate in 2012 due to really non-compliance. We had given them these tablets. We had these caps that we could record how many times it was open, and we were given back bottle empty, 30 tablets empty, but it was open only once. So you know what he did. He just chucked it and gave me back the bottle. So we didn't tell the patient that we are recording. There's a chip in there that records how many times you're opening it. That's a compliance issue. Another thing is the patient goes to our clinic in Chinese U, but he's free to go to any other clinic also. So when he has other disease like high blood pressure or anything, if it shows up, we can see it from the database. He has gone to this clinic, he has taken these drugs, and they don't report this back to us. So whatever results we get back would be very confounding. So we had to terminate the study at that time. But one interesting thing I have to tell you, that although we stopped the study, the clinician came back and he was recording that those who were taking the Shequite drug, they came back less frequently for recurrent episode up to now. And those who were in the placebo starch group, 9 people came back for recurrent episode. Now this is still, I would say it's still confounding because there are those people in the patient group who did go and take other treatments elsewhere. And of the metabolic parameters that we measured up to that 2 years, there was no statistical difference in general. Again, these results do not count. It's not valid because, as I said, they don't report back honestly what they were doing, and we are not sure whether they took those pills or not. And metastable limit in 2 patients was significantly increased. So this is my final slide. And what's the future prospects and overcoming hurdles? One thing is source and quality of the herbal medicine should be standardized. This is absolutely essential. You cannot have 2 different sources with 2 different composition. Even if it says Earl Grey tea, it's still different. It has to be well designed and regulated. And if people are going to take, if your patients are going to take alternative medicine, it has to work synergistically with the Western medicine, whatever they're taking, whether it's diuretics or analgesics. So it has to work synergistically. We still have poor understanding. And as I told you, there's only a handful of clinical work available out there. Some giving positive results and some giving basically there's no effect. So there is not enough data out there. And compliance is a big issue, I think. That there's no way, unless we can send somebody to the patient's house, here, take the pill, you see him take it, put it down his throat, well, they can hide it behind also. But this is still an issue here. And I think from the data that we have collected, the metabolic and dietary risk data, it is worth doing these follow-up studies. But we need to give them some motivation, and I think Dirk alluded that earlier, that patients, because over there it's a lifestyle issue. ESWL is really a lifestyle issue. So I thank you and thank the organizers for giving me this opportunity, and just to acknowledge my collaborators. Thank you.